All right. Well, good afternoon, everyone, and good morning to our friends on the West Coast. Thank you so much for joining our webinar on building a modernized and connected public health system through multi-sector partnerships. I'm thrilled to be joined by two incredible state leaders here who will share how they're working to promote a public health system that's robust, interconnected, and capable of promoting the health of all communities. You can go to the next slide. For those of you that weren't aware, in September, NASHP released a Public Health Modernization Toolkit focused on providing state leaders with practical strategies for strengthening collaborations between public health and the healthcare system. Really, the driving idea behind the toolkit and this webinar, in fact, is that public health really works best when it embraces its role as a convener and catalyzer at the state and local level, bringing together the healthcare delivery system, human and social service partners, and community leaders to really drive collective action towards improved community health. Next slide. Building a public health infrastructure and culture that facilitates these partnerships also really requires deliberate strategies to break down organizational silos, implement processes for engaging communities in decision-making, aligning multi-sector resources and financial incentives, and improving data exchange across partners. You'll hear some fantastic examples of these partnerships at work today, with many more in our toolkit, which provides really a framework for key priorities and a menu of strategies and innovative practices for aligning public health and the broader healthcare system around key priorities. Next slide. And lastly, I just want to say that we're thrilled to feature some really great leadership strategies from states here. So please let me introduce Dave Baden, who's the director of the Oregon Health Authority, and Dr. Natasha Bagdasarian, who's the chief medical executive at the Michigan Department of Health and Human Services. Both Dave and Natasha will share how their states are working to build public health partnerships at the state, local, and community level. And then we'll have plenty of time for discussion on the role of partnerships in improving health outcomes and trust in public health, and how these partnerships can really better center the needs of communities. So please stay muted. If you have questions throughout the presentation, feel free to go ahead and put them in the Q&A section, and we're looking forward to a great discussion after we hear from both our presenters. So with that, I'm happy to hand it over to Dave.
Yeah, thanks, Katie. Thanks for having me here today. Yeah, I am Dave Baden, Interim Director of the Oregon Health Authority. I use he, him pronouns. Happy to chat about what, is such an important topic of how to make all of this stuff work at a local level and connect various systems, communities, partners to really deliver a more modern public health system writ large. So just maybe a little bit about me. I've been at OHA for 5 years. Before that, I worked at CDC for a long time, including working overseas in Kenya, in CDC's office in Kenya. And I just was sort of thinking about living and working in a place like Kenya, of how health and healthcare, public health, only works through connections at a local level. It's a lot less about sort of the government bringing services to people. It's people figuring out how to work together to to reach and try to access services that may be available. And I think just sort of thinking through that today, of how we, in a pretty stovepiped health and public health system, how we break through those barriers that do exist, both at a federal, a state, a local, and sort of a system level. How do we break through that to, really improve health of all people, and sort of look at public health a little bit more broadly. And I think especially for me coming into the health authority, really broadening out this view of what public health is, and that the public health system includes healthcare, it includes local community-based organizations, it includes social services, and how we talk a little bit differently in the public health system. Even the term public health infrastructure, I think, can be misconstrued or heard very differently from people who aren't sort of steeped in the public health system. I mean, infrastructure for lots of people means different than what I think we think about public health infrastructure. Next slide. So the Oregon Health Authority, for those that are not aware, we're one of these sort of superstructure agencies where a group of things all report up to a health authority director, including Medicaid, public health, the whole behavioral health state system, our health insurance marketplace, as well as the Oregon State Hospital, the large psychiatric hospital in the state. So all of those things reporting together, and the vision of what that does is that it's all about interconnectivity. It's all about how to provide better care, lower cost, and achieve better health outcomes, while very much focused, as we'll talk about here in a second, about eliminating health inequities. And what OHA is really trying to move forward on is looking at all of its programs, really digging in and understand the structural inequities and the structural racism that are inherently in the programs, dig in, involve community differently from the beginning to really try to transform healthcare more generally. Next slide. So as I said, our goal with sort of the vision that I mentioned before is to eliminate health inequities by 2030 in Oregon. It's one of those pretty ambitious goals, I would say, to really push that out there. But again, what we're focused on in all parts of our agency is to look at how we move Medicaid and the health system further upstream, learn from public health, and maybe bring public health a little bit more downstream into the health system, and how we, again, do this in a way that really focuses on those people in Oregon who historically have had trouble accessing services throughout there. And for me, that is a modern public health system. How is it that we have a public health, a healthcare system that is able to address needs of all the people that are in the state to create a more equitable, culturally and linguistically responsive public health and healthcare system? Next slide. So I did, in the spirit of building good partnerships here, and admittedly, I think public health historically has not talked as much about how sort of the healthcare infrastructure, whether Medicaid, the health system generally, how it can be sort of seen in this modernized public health system as well. There are a lot of Medicaid and other activities that are going on here that really will help benefit the overall public health of the state, that are really being driven through a very innovative Medicaid program in a couple of ways. I won't go through all of these for purposes of time. I will hit two of them. The first one is around this continuous coverage for young children. Oregon is one of the first states to have the ability for kids, whether they're born in being covered by Medicaid or at any time through the first 6 years that family's income or other sort of factors get them covered by Medicaid, is that they will be covered regardless of income changes from birth to age 6. So for all the public health practitioners out there who talk about sort of early childhood interventions and ACEs scores and all of these things, I would love for more research and looks about what this will mean for kids. Again, we're about half the births each year in the state of Oregon are Medicaid births. So we have a very significant portion of the population in this state that will be that will have coverage from birth to age 6. that is a modern public health system, is to have access and coverage for young kids. The other one I really wanted to cover is the last one on here. We're doing a lot of really interesting, innovative things to assure as we go through Medicaid redeterminations that every state is going to catch people. But I did want to talk about the Healthier Oregon program. And so what the state did with over $500 million of state general fund is assure that there is health coverage regardless of immigration status in the state of Oregon. So if there is a person here in this state and they meet income qualifications, they will have access to Medicaid services as delivered by mostly our coordinated care organizations in the state, which are our Medicaid managed care entities in Oregon, regardless of immigration status. So we estimate over about 50 to 60,000 people will be covered through this program that fully expanded back in July. And just really want to think through and talking about the great stories that are happening because of that. Already we are hearing people who have been living in Oregon for 20 or 30 years who never really had access to coverage before, are able to get preventive care, get a dentist appointment, have access to some home and community-based services support, unlike ever before. So this is a really core tenet now of Oregon's system. Next slide. So again, I won't, trying to keep us going on time. We are really trying to assure that people do maintain coverage with those in Medicaid. I'm sure many of you have seen a lot of national stories about some states that have had 50 or 60% of their Medicaid members that have lost coverage. We really are taking a different tact here, which has led to so far less than 15% of those that have gone through Medicaid renewals of having their benefits ending. Next slide. Okay, so all of this it is about sort of, I would say, just generally having a more modern public health system generally. And, Oregon very much was an early adopter and an early push leveraging federal funds, but really going to the legislature over the last, nearly 10 years and asking for and receiving investments from the Oregon legislature to modernize and connect things together. Again, under our state health improvement plan to have a more modern public health system. You could see, and I think one of the key things that I want to emphasize here is how we also have looked at and provided some direct funding over time. You could see it started with some state support and support to local public health agencies, but as it has grown, and especially as what happened in the pandemic, the value of directly funding community-based organizations in partnership with local public health authorities is really important for a more modern public health system and to better meet needs of Oregonians from trusted partners, trusted community groups, communities of color, churches, and others where people really get their support. Next slide. So I think for the state, the lesson of funding and having a more modern system, and also trying to change power dynamics and listen to community and community partners, especially of communities of color in Oregon, to again push to eliminate health inequity. And in COVID-19 vaccinations, it was a clear and present danger in front of us that vaccinations were trying to alleviate. And I will say, as we started down the COVID vaccination path, we were failing. We were, I think, like most other states, in how we were delivering vaccines, for many people in Oregon was not a trusted place to go. While efficient, large mass vaccination sites that especially had sort of National Guard support and others, created barriers for people who saw people in uniform or saw sort of a more thing that really turned them off. And with all of the history of testing and other things, especially in African American and Black communities in the United States, there was a lower vaccination rate. We heard directly from Black leaders in the state that we needed to change that. And how we did that was direct sort of funding, support, and opportunities for tables and grants to do the work differently. You know, we did a $45 million grant program in the pandemic, funded by ARPA dollars, actually CARES Act dollars, to really in a very sort of hands-off way say, hey, community-based organization, what do you think your community needs as it relates to COVID? It could be rent, it could be food insecurity, it could be housing. All of those were on the table. And we made an application very simple so that there was not a 80-page sort of set of things that we asked for, knowing that it was an emergency. And we made the budget document very simple. And then we got out of the way and answered their questions and let them go. So I think as examples of things where the government needs to sort of to modernize itself and react to the needs of community differently, it's also how we put our grant mechanisms out there. There are a lot of barriers that get created in how we do our work. So with this, is that it worked? Is that over time with a lot of work, is that you know, Oregon's COVID-19 vaccination rate for Black, African, and African American, African immigrant communities exceeded the rate for whites and is the highest recorded rate in the nation for that community. Next slide. Okay, I want to talk a little bit about the work that is being led by our public health division around really trying to braid funding together. I know this is a concept that gets talked about in NASHP and in other places of how do we take what states get, what local public health gets, and lots of myriad different ways from CDC or from other sort of grant opportunities, SAMHSA and others, and how do we braid this together to do this? And what we really focused on is braiding it together for a really strong focus on equity. So really looking at various mechanisms from CDC, from the state, and you know, braiding grant opportunities from 8 different programs into one application. So what that allowed is really more money available to do this work. And it sort of allowed a broadening and a little bit of more of a whole public health approach to this work, and excited to keep going down this path. Next slide. So as I said up front, I think Oregon really is trying to bring the medical system, especially with a focus on Medicaid, more upstream, and sort of bring the public health system to meet it, take the lessons learned from public health science around social determinants of health and moving upstream. And we have a new Medicaid waiver that will provide over $1 billion in federal funding over 5 years that focuses on upstream work in housing, nutrition, and climate services. I do want to hit the housing piece, and then I will sort of rush through the last couple of slides so that there's plenty of time for the next speaker here. So next slide. So I will say that really excited to get this work going. Just under a year from now, Oregon, as a Medicaid benefit, will really be the first state to test out how this works in Medicaid, to move upstream to have a Medicaid benefit for at least a subset of Medicaid members to provide rent temporary housing for up to 6 months, other sort of housing navigation and services, to at least how we're starting is to keep people housed and see what that means for their access to medical services, their access to behavioral health, dental services. How does this work? Is it going to lead to, with someone having a more stable house, at least over 6 months supported by Medicaid, will this lead actually to them accessing services more readily and differently? That's the work ahead of us, and excited to do this. All right, the next couple of slides, I'll just show and go quickly because I do want to get to the next speaker and plenty of time for questions. So we have, again, another unique benefit to provide medically necessary devices in climate emergencies. Next slide. And then expanding some benefits that are around nutrition. Again, so many linkages to public health work about healthy food and fruit and vegetable prescriptions and the like. Next slide. All right, with that, thank you. And I will turn it back to the group and go from there. I look forward to questions.
All right, thank you so much, Dave. So much to dig into here, and really appreciate your points around Medicaid and public health working together. So for now, I would like to turn it over to Natasha to talk a little bit about how they're building connections in Michigan.
Thank you so much. I really love the fact that Dave went first and got to talk about public health from a very big picture lens and got to talk about his super agency. We are also part of a super agency here in Michigan. I am the chief medical executive, but the agency is much bigger than just public health. The Michigan Department of Health and Human Services is also comprised of Medicaid, the state psychiatric hospital, and so forth. Very similar to what Dave was describing. But what I would like to talk about today is a very small view, and in fact, just a few examples of some work done by a group in Michigan called the Public Health Advisory Council. Now, this is a state governor-appointed advisory council, which I chair, and this is a group with no funding. So this is a group that can make recommendations to the director of the Department of Health and Human Services and to the governor, but doesn't have funding to enact these changes. And I want to give you just some ideas of what we have done with essentially on a shoestring. And now we've been able to find some funding for pieces of this. First slide, please. I'll start out with just again, very big picture view of some of our discussions that took place on this Public Health Advisory Council. When we talked about the need to strengthen public health, we talked about essentially two things. Number one, public health infrastructure, which you all know and understand the struggle of our issues with inflexible funding streams, data systems, and of course, workforce. But then we also talked about another bucket that is a little bit more vague and ill-defined, but can sometimes be done with limited funding. And that is to strengthen trust in public health messaging. And we've really seen the effects of the politicization of COVID has really impacted the trust in public health messaging here in Michigan. We've seen this in our vaccination rates. We've seen this not only with COVID vaccine, but with routine childhood immunizations, for example, which have dropped during the pandemic. So we are talking about rebuilding relationships with communities, partnering with trusted messengers, and working on the message, the public health message, which is often disjointed, not cohesive, can flip-flop, and in the past has struggled with the ability to convey uncertainty so that when we do need to pivot, it's seen as a flip-flop rather than a change in data and a reinterpretation of data. Next slide, please. What this group decided to do first was we wanted to really hear from folks who had been critics of public health, especially during COVID. Again, here in the state of Michigan, there had been a lot of politicization during COVID of public health interventions. This may be true where you live, but here in Michigan, there were some groups who had very strong feelings about public health, and we wanted to make sure that we spoke to not only folks who were involved in public health, but also to our biggest detractors and to folks who really thought we had done a terrible job. And so we conducted a series of semi-structured interviews with some of the following: local public health officers, state legislators, health plan leaders, law enforcement, healthcare providers, and other advocacy organizations. And again, we made sure that we were talking to folks who had both been involved in public health and who understood public health, as well as folks who maybe did not have a great understanding, and folks who had been detractors of public health. Next slide. From those semi-structured interviews, we saw some themes emerge. And then from those themes, we developed the following 7 recommendations. So number 1, to improve the connection of public health to the healthcare system. As a physician and working outside of public health for most of my career, I really saw that as clinicians, we very often don't see the public health perspective, the public health data, or what's happening at a community level. We're seeing just what's happening with our patients in front of us. Number 2 is to improve knowledge of public health among legislators. And this was really because in our semi-structured interviews, we were told by legislators that they didn't understand what public health was. And so if we want more funding, if we want more flexible funding, we have to be able to communicate what it is that public health does to the people making decisions about that funding. We wanted to improve knowledge of public health among the public. During COVID, there was a perception that public health was mask mandates and closing down schools and restaurants, and a realization that much of the public doesn't think we do anything outside of those things. And again, in order to advocate for support and funding of public health, we really need to tell the story of what it is that we do. We, of course, want to improve public health data systems. This is the story of everyone's life in public health. We got requests from local health departments to enhance technical assistance and leadership training, especially communication training for local health departments, many of whom don't get communications training as part of their job. We were asked to improve communications between the state and local health departments and improve advocacy for flexible funding for public health. I wanted to just focus on 2 of these things: the improving the connection of public health with the healthcare system, and then improving knowledge of what public health does among the public. So I'll touch on just those 2 examples. Next slide, please. Now, with improving connection of public health to the healthcare system, we came up with some concrete requests. Again, requests that could be done really on a shoestring budget, or perhaps without a budget at all. And so far, these initiatives have been a success. So first of all, public health grand rounds. I mentioned that as a clinician, I often didn't know what was happening in the world of public health or what was happening in my field at a community level. And by training, I am an infectious disease physician. And a lot of what I do is should be very community focused. We should be thinking about outbreaks at a community level, antimicrobial resistance. And I didn't have that perspective before I came and worked in public health. And so we started a public health grand rounds for the infectious disease community. And for those of you who are familiar with infectious disease doctors, we are a very small group. There are not many of us. And even with this very small community, public health grand rounds has been a hit. We've had 2 public health grand round sessions so far. We've had 400 people join each of those sessions, and that includes folks from local health departments, from the state health department, and from the infectious disease community. People love the content and seem to want more of it. We talk about big outbreaks that have happened around the state. We had a blastomycosis outbreak we had an infected bone graft with TB, and folks really loved hearing the investigation and what came of it and how folks were handling those cases. So it's been a big hit, essentially required no funding. We conduct this by Zoom and partnered with our Michigan Infectious Disease Society. The plan is next to come up with a public health grand rounds for the primary care community, who again, as I've gone around the state talking to folks, there is a lot of interest in joining those conversations. Number two, healthcare coalitions. One example of a healthcare coalition is a group of our pediatric hospitals who come together and actually meet every week during respiratory season to discuss bed occupancy, ER burden with RSV, influenza, and COVID-19. They just had their meeting today. It's just 15 minutes long, but it's a really great opportunity for folks to come together and talk about what sort of demand we're seeing on patient beds and what requests they have from the state or from each other. So a lot of times there are requests that only certain quaternary care hospitals can accommodate, and they're discussing with each other how to best allocate those resources. So this has been really very helpful. And it's also encouraged the hospitals to update their data on bed occupancy. So we have a live dashboard that shows us pediatric and adult bed occupancy with COVID, influenza, RSV, ventilator use, and ICU occupancy. The other initiative that we've had is, and I mentioned this briefly, but our vaccine uptake, our routine childhood immunizations have really plummeted since the pandemic. So we had been seeing about 75% uptake of routine childhood immunizations for 3-year-olds in 2017. That's gone down to 66%. So we are really concerned about this. And we had a multi-sector meeting where we brought together the healthcare payers, the vaccine manufacturers, the health systems, other folks concerned about this issue, and brainstormed innovative ways to bring vaccines to communities, including things like engaging with dentists on HPV vaccine, because they can best talk about head and neck cancer, for example. Next slide. And then quickly, I just want to mention a couple of points on improving knowledge of what public health does among the public. We did get a little bit of funding to put together a This is Public Health campaign, hopefully to better inform the public and legislators about what it is that we do and why what we do is more than COVID and masks. We also have a Trusted Messenger campaign, again, that we found a little bit of funding for. This is a campaign that our local health departments will be initiating in partnership with a group called PGP, or Partnership for Public Good Project. That's what it is. Where essentially they look at particular geographic areas and what types of misinformation folks are coming up with on Google searches or on social media. And then they have a team of journalists who put together materials that are specifically countering that misinformation that can be sent out to community organizations and put out in a way that is not branded as public health, but it is branded or associated with community organizations that people know and trust. And so it's another good way of improving perceptions and putting some good information out there. And I think that's all I have. So I will hand it back to the NASHP team and maybe for discussion now.
Wonderful. Thank you so much, Natasha. These are some really great examples. So again, just as a reminder to folks, please do feel free to put questions in the Q&A. We will try to get to everything, but in registering for the webinar, we did have a number of people send us questions in advance, and a number of them really focused in on really what's the best way to start? How do you start connecting with partners and really ensure broad representation from interested groups across the work that you're doing. So would love to, maybe Dave, we can start with you.
Thanks, Katie. Yeah, I mean, I think, first and foremost, I like it. I mean, I think it's what you said. It's relationship building and building trust, and I think to what Natasha was talking about, right? There is so much skepticism about public health, about government generally, in lots of different ways, in lots of different communities. So how to find ways, find ways, again, I think that's where the power of different community-based organizations, faith-based organizations, where people still do look for community and sort of connection in different ways, and how can, sort of building, building relationships with local leaders, with heads of these community-based organizations, to answer their hard questions, to get through a little bit of why, like, why should they spend their own sort of human capital, their own in supporting or working with a state or local public health on particular issues. I think that's where, I mean, where are some of those catalyzing issues that people can get together on? There were moments in COVID where that happened, and many moments where it didn't. But I think there are other catalyzing issues that the system, from what's happening across the country in fentanyl and sort of overdose work and prevention. I think that there are other ways of entering into space to where it isn't, hi, I'm with the government, I'm here to help. It's flipping that around to listening to what the needs of community are first and reacting to that. And that sounds trite in some ways, but like, if it is real and it is seen, and when it isn't done well, you will lose people like that. And so that piece of this is just so important, to take the time to show that you are there to hear what their needs are, and not bring sort of upfront, here's what you need to do, community. That just doesn't work.
Natasha, anything to add?
Yeah, I thought those were excellent points. I'll just say that, I don't think that there is a one size fits all answer for everyone, and everyone's setting, everyone's state is going to have different needs and requirements. How I went about building some of these relationships in Michigan was just, first of all, seeing who was receptive to some of these relationships and which of these relationships just seemed to be the best fit. So for me, as an infectious disease physician, some of my relationships started with that community because I already knew them. And from there, I think I have gone where people have shown an interest in engaging and having conversations. So I essentially never say no when someone invites me to come, especially if someone invites me to come and see them in person. I always say yes, because that shows a willingness to engage and have a dialogue. And something may come of it. There may be an opportunity to collaborate. There may be an opportunity to build something great. It may fizzle. But one of my approaches has been just to see who's been interested and sort of going for that low-hanging fruit.
Yeah, absolutely. And then brings up, I think, another important topic, which is making the case for public health, or what's the value proposition of working with public health in these partnerships. Curious about what you found to be successful and what makes these partnerships work. Natasha, we could start with you.
We are in the early days of some of these partnerships. And so I am still figuring out what is going to work. But I think whenever we've brought people together, folks are really looking, especially post-pandemic, for those opportunities for discussion. And as Dave mentioned, people want to be heard. And so being able to have discourse and discussion and to feel heard both by the government, the state, as well as by people in other sectors that they don't normally get together with. Our vaccine champions meeting was really, really well received. And I think in part it was because we brought people together for discussion who don't normally talk to each other. So offering a venue to feel heard, I think, is really valuable right now.
Yeah, and I think the only thing that I would add to that, I mean, I think that, yeah, recognizing sort of the space and, you know, the history that, you know, that is there. I mean, I think the, you know, especially into communities of color, of the history of, you know, of public health, frankly, sort of colonizing and using data. Hi, I'm going to extract in an extractive way. And again, how then the community, how do you build trust of, you want to know what? And how do you change that to where it's that listening first, you know, from there. And, you know, I think that, you know, to Natasha's point, it's, again, how do you find potential champions that can be a little bit of the trusted voice when there will be folks that will never want to hear from the Oregon Health Authority ever. And if I would show up and give that speech, they would turn off from the very beginning. And but maybe there's somebody else in the community that that they would listen to that still is getting the same message out. There's, I mean, to Natasha's point, there's so much to rebuild, even in vaccine hesitancy, and you see it in child immunization rates. You see it in, you know, we just put out a study of our healthcare flu and other immunization rates, and they've plummeted. That's bad. So we've got a long way to grow and to rebuild some trust, and that won't come from, I think, just direct government into various communities. It's how do you find and build advocacy and have conversations where people, like, you know, that it doesn't look like it's OHA talking to them.
Yeah, these are all great points. And I think one important point is also that public health needs the capacity to undertake these partnerships. And capacity has been a huge challenge, as I think both of you have brought up. I'm currently calling in from APHA in Atlanta. Public health infrastructure, very, very hot topic, of course. And we had one question about really what's the greatest challenge in building public health infrastructure and how are you addressing it?
I can start. I think, I'll let Dave sort of give a fully fleshed out answer, because I think Dave is more in tune with the funding parts of this. But I think for us, a real struggle has been the lack of flexible funding. I think we saw this during COVID. We were dealing with COVID, and then MPOX came our way, and we weren't able to pivot and adapt as quickly as we could have because we simply don't have the flexibility in our funding. And without that, I think you're stuck doing things the same way they have always been done because your hands are tied when it comes to new approaches.
Yeah, thanks, Natasha. I feel like I, in my 20 some odd year plus, it's sort of my my sort of, I have a dream in public health that one day we wouldn't have 65 separate grant agreements that we have to get as the state to manage through. One day Congress will hear and change things and do that. But I think Natasha's spot on. It's hard to build infrastructure when you have to sort of focus on 60 different specific things. How do you build a system that manages that instead of 60 different little things that you piece together? You can braid as much as you want. You can try to do that, but until there is an opportunity to truly be flexible, and also I think the the integration between medical and insurance systems and social services into looking at this more holistically. Again, I think some things that we and other states are doing in Medicaid to push upstream. I mean, I would just encourage those who typically swim in public health sort of funding cycles to really be partnering with your Medicaid agencies to think about how those things go together. Right? Medicaid and CMS is swimming into public health space. I think that's awesome and fascinating. And I think CDC needs to do more to swim more into the CMS space. They could meet somewhere in the middle and go from there. I like the amount of money and the resources that are available when you get into the Medicaid space is very real. And that sort of set of partnerships on the federal level. And I would, if you work in a public health department, how often are you chatting with your Medicaid team? My bet is it's not that often. And you need to do that more because there's a lot of innovative things that are happening where I think that partnership to build an infrastructure can happen.
Yeah, this is I think a fascinating topic. And you both mentioned that you are from Uber agencies, I think is the term we tend to use, but agencies that oversee Medicaid, social services, a lot of different things. Wondering if you could just talk a little bit more about how you're building those relationships between public health and Medicaid in particular. Dave, I imagine you've already touched on this, but if you have tips, especially for other states that may or may not be under one of those larger agencies.
Yeah, I mean, I think de-siloing or breaking through that. I mean, in some ways, I would, just because we're a super agency, those silos still exist. So you have to, you have to still be thoughtful and really working through that. I mean, I would argue that the COVID response is an example of how having a super agency, where in some ways it's a little easier to ask your colleague in the same agency to come help than to go to another agency and say, hey, come over here to our agency and help us. That I know from my perspective, from our state public health, state health officers' perspective, was instrumental in sort of having more leadership to respond to things. I had another thought, it went away. But yeah, I mean, just one other specific example. I think I had mentioned we're doing some nutrition upstream work on the Medicaid waiver. The person who is leading that effort is from the public health division, who leads sort of nutrition work paid for through sort of mostly CDC chronic disease sort of funding options. That is great. Why would we need someone else when that expertise has been and comes through public health? So how and where those happen, is, I think, again, and like, we are not the only state that is looking at these upstream models in Medicaid. As NASHP would attest to, like, I think half the states were talking about this at the NASHP conference here back in Boston. So I think there's lots of opportunities to try to work together.
Indeed. Natasha, anything to add from the Michigan perspective?
I just want to add, I'm very used to talking about all the things that COVID made worse. And there are really too numerous to even count. This might be the only thing that COVID actually helped with. Because there were so many hands on deck with COVID, many of the folks that we pulled into public health are folks who normally work on things that are completely outside of public health under normal circumstances. And so I think for this post-pandemic time, everyone in our super agency has some familiarity with the work that public health does because of COVID. So either they were working on vaccines or testing, or it was really all hands on deck. And I just hope we don't lose that. I think that we had a brief moment in history where public health had all eyes on it. We had all the attention, we had a lot of funding, and I hope that we don't lose that momentum, because this is really potentially our only opportunity for the next several decades to rebuild and use all of those resources and relationships that we happened upon during the pandemic.
Yeah, absolutely. So I want to get to a question in the chat, which is for Dave in Oregon. Until we reach that dream of flexible, non-categorical funding, we are at times forced to be creative around blending and braiding funding. Love the model that you're using with CBOs. But Anne's question is specific to, how do you approach blending and braiding, just given the differences in reporting requirements, application requirements? How are you navigating all that?
Yeah, no, it's a great question, and like I think sort of two steps forward, one step back in some of these things. I mean, I think at least for a state health agency, state public health, it is sort of more work up front to to try to look at the myriad of funding that comes in that you want to try to braid to get at whatever sort of goal that you're really trying to get to. For us, it's having a stronger push toward health equity funding and supporting local public health and CBOs in a variety of ways to take some lessons learned from COVID and go from there. It's a lot of onus on the state to look through and make the reporting requirements as seamless as they can be. So it's not just, oh, look, we braided something together. Here's your 75 different reporting things that you now need to do. So, I mean, I think that's a little bit of work in progress of trying to, sort of braid and then braid the rest of the requirements that go through that. I'm not sure that we have it completely right. The other call out I want to sort of say is, I will say that it is both a challenge and an opportunity to where if the state is directly funding community-based organizations, how to assure that local public health does not see that they're being left out, because they also are getting funded. But I think it could be seen very much from local public health of, wait a second, we should be doing that locally. Why is the state funding those things? So how to build the right local coalition to where local public health is part of and sees the benefit not only to them, but to their communities of how that sort of joint funding model is there. And that is a challenge, because at the end of the day, someone will feel like they're getting less money than they could have been getting if you do that model. So how you can have the right, again, every state has sort of different models of state local public health, who does what, but for states that do fund a local public health infrastructure, that piece is really important, again, to what the focus of this discussion is, which is about partnerships.
Yeah, absolutely. And I know we're winding down on time, but maybe one final question for both of you. Throughout what you've presented, I think there have been a couple times where both of you have alluded to, something being a work in progress. So just curious, for any other state or locality that might want to invest in similar approaches to some of what you've described today, are there any lessons learned or advice you would share based on the work that you've been doing on this topic?
I can go first.
Jump in who would like to. Yeah.
Yeah. I think that for us, having those listening sessions in the beginning were really valuable. I think it was really important for us to hear from our local health departments, our local sheriffs, our legislators, what the needs were here and where they felt we were missing the mark in public health. And so I think starting by defining the problem in your state, in your area, it was very helpful for us.
Yeah, I was going to say something very similar. I think how to, through whether listening sessions, really trying to change governmental power dynamics and build, understand, and listen to the communities that we say that we want to serve. How are we listening to them and reacting rather than bringing solutions that they may not want? So that piece of this is hard and time consuming. But if you don't do that, I think at the end of the day, I think I think it could turn more people off, and I think just continue down what I think Natasha talked about very well, sort of the struggles of what is public health and what, how is this benefiting my life? And, so that will come to listen and understand problems. And likely you will hear about things that are typically outside of the public health domain: childcare, nutrition, well, maybe not, childcare, housing. Just sort of core pieces of that person's ethos. That still is public health. That is still about them having all the tools to thrive. And how are we listening and bringing partners in to help?
Absolutely. Well, much more work to be done, and that might be another webinar entirely. Great note to close on, all really important points and such important work that you're both doing. Thank you so much to both of you for a fantastic conversation. For everyone else, thank you for tuning in. We will post a recording on the website if you'd like to share or tune back in, and just really appreciate the work that you're all doing. Thanks so much.